Oh, there's a mission down the street. They had a pool. Sold in 2 days. I said, how much, John? 475. Oh. I always very slow, painfully slow. Thank you for joining us, Charles.
Okay, with that being said, I'm going to go ahead and kick this off. I want to welcome everyone to ACMI, the Association for the Chronically Mentally Ill. And we're excited tonight to bring this webinar on medications. Again, please mute your lines, send your questions via chat. We won't always interrupt immediately because we know, and everyone may want to mute. There. The doctors are glad to answer questions on medication topics, and they've covered quite a bit in their presentation. They aren't treating specific patients, so asking for med changes for specific patients over in a webinar isn't appropriate. I mean, they're glad to talk about side effects and what the gold standard is, but not treating you or your loved ones on a call. Okay, and all of the recordings will be available along with protected slides up on our website, acmionline.com. So with that, let me introduce, we're going to do an override of psychiatric medications with Dr. Alicia Cowdery and Dr. Beth Darling. They both are extraordinary physicians, and they have a wealth of knowledge and information. And something that you probably won't see in their resumes is that they both have had some training as caseworkers, which I always think it really helps and adds to someone's grasp of what it takes and walking in patients' and families' footsteps, is that they've been down in the trenches. So they have a lot of knowledge to share. And with that, I'd like to introduce Dr. Alicia Cowdery. She's the medical director of outpatient services. She also is over the First Episode Center, associate program director for adult psychiatry residency program. So she is one busy lady. And also Dr. Beth Darling, medical director and she's also over the Mesa Riverside Assertive Care Treatment team. So I'm welcome to produce both of these very well-known established psychiatrists, and I'll kick it off to you two.
All right, hi, it's Alicia Cowdery. Hello to everybody virtually. Nice to see you all. So we put together this presentation to kind of just overview a lot of the medications we prescribe, how we do things, why things happen in certain scenarios, and kind of the art of medications. There's a lot of information in the slides because we want people to be able to go back and look at them, but we'll kind of hit the highlights of these things and really talk about how it is that we've come to practice medicine and the reasons that we do different things. So the objectives are to provide information about how we use the art and science of psychiatry to prescribe medications. We want to provide information on the specific classes of medications that we generally prescribe, why we prescribe them, and then common side effects people might see. We also want to discuss challenges commonly faced in psychiatric medication management, and then provide resources for patients and families about the medications that are scientific and good resources, because there's a lot of information out there on the internet and it can be very confusing to sort through all the information. So we want to make sure you have the right place to go. The first things we'll talk about is that medications do play a role in treating many psychiatric health conditions. And you have to choose the right treatment plan based on a person's individual needs and medical situation. So not everything is going to be the same for the first person to the second person. We have to take the whole person into context and all of the things that they're experiencing. You want to make sure you're seeing a person who has experience treating the medical condition that the person or family member has. We want to do routine medical assessment. Our job as psychiatrists is to be medical doctors first. We want to rule out any medical issues that might be going on that might be causing psychiatric symptoms. So with that, you want to do focused physical exams. We want to look at the person's height, weight, blood pressure, do a neurological exam. We want to make sure there's nothing going on with the thyroid or anything else in the body prior to jumping to the prescribing of the medication. So that'll include general labs, EKG, urine drug screens. So we also have to look at is recognizing and appreciating the risks and benefits of the available treatment options relative to alternative treatment or no treatment at all. There are times where we might do some watchful waiting or try some alternative treatments based on a person's preferences. We're always going to present what we know about science and clinical information, but it's also going to be important that people may have alternative treatments such as vitamins or other natural things. And so talking with the provider about those things to see what's in those natural elements or vitamins, what we can do to add that to the treatment as long as people are not having any harm from any of those alternative treatments. So all therapies, including placebo, involve hazards that could either worsen something, think about having side effects that might be intolerable, or indirectly might worsen the disease. So we practice a balance of this through gained knowledge and experience. So we have to actively collaborate with primary care docs and specialists. As we all know, those guys are very busy. And so psychiatrists spend a lot of time coordinating care with primary care docs and specialists because oftentimes our patients aren't getting a full medical workup. So it's an important role for psychiatrists to really push that and make sure folks are following up with primary care. And so to make sure that we are working in conjunction and that we're not, maybe something I'm prescribing might be causing an issue that needs to be seen by a specialist. So we want to work together on those things to make sure that the appropriate care is given. We also have to talk about lifestyle issues that can co-occur with psychiatric conditions, maybe related to obesity, hypertension, sexually transmitted diseases, or things that are caused by our treatment. As we know, some of our medications can cause weight gain, changes in metabolism. And so we really want to work on the whole person to say, maybe it's not just the medications. We need to look at the whole health of, are people exercising? Are they eating nutritious foods? Are they doing other things to make sure that they stay healthy in addition to knowing that the medications can cause those things? So an example that we always look at is it's really important to look at balancing the life-saving effects of the medication clozaril, which is an antipsychotic, for a person who is obese, pre-diabetic, chronically suicidal, and has significant psychosis. So those are two, things that are pretty challenging to manage, and we have to weigh the risks and benefits to see what's going to be the best thing. Is it better to treat the chronic suicidality and psychosis, or do we need to be more mindful of the obesity, the diabetes? So it's a mental balance that we partner with our patients on. So other things we have to look at is differentiating adverse drug reactions from primary illness symptoms, because this can be really challenging because oftentimes they can overlap. So I'll give you an example of akathisia, which is a restless feeling that people feel from some antipsychotic medications. It might cause them to pace around, feel really restless, feel like they got to get this energy out of their legs. But that could also look like anxiety or hypomania. A person might pace or be restless because they're experiencing those symptoms. So really teasing that out is going to be incredibly important. I'll show you a slide on the next slide that has the side effects of antidepressants versus the symptoms. So one of the things we have to look at is timelines. It's going to be really important. And we as psychiatrists are detectives. We want to know exactly when you started the meds, how you took it, how long you took it, what exactly did you experience and when. And those may seem like very detailed questions, but it really helps us in our mind figure out what the next step is. Because if a person only took a medication once, because they just didn't think it worked. But it's a medication that doesn't work for 4 to 6 weeks. That's not an adequate trial, right? But if they took it once and it made them incredibly nauseous and vomiting, that's a different scenario about the medications. So really getting a really solid history of treatments and their specific causes and effects is important. And then there's also something called a nocebo effect, which is a non-specific things that people might notice. They might correlate with the patient's expectations. Like if the person says, you know, my sister went on Seroquel and she gained like 200 pounds, they may perceive that that's what's happening to them when there isn't even a weight change we might see on an actual scale. And then particularly if they've had a bad experience or, you know, just kind of have past experience that got a really high dose of a Haldol at an urgent care site facility, they're probably not going to want to try that medication again.
One thing, Dr. Calvin, if someone tells you they're taking the doses as prescribed and they really aren't, then are you baselining them at that dose, and then are you more likely to kick it up?
So yeah, and that's something that we really try to partner with patients on, is understanding how they are taking it. And so asking those questions in a very non-judgmental manner. So tell me how you take the medications. How many days a week do you forget? How many days a month did you forget? Because people will tend to be a bit more honest that way if you set up the expectation that it's okay that they did, versus you say, like, you know, you took it every day, right? That's not really, the way we ask questions can be really helpful to those things. But I also just have an honest conversation the first time I meet somebody, is that, you know, if you're telling me you're doing something and then I'm trying to titrate up on the medications, it's not going to do us any good to be hiding information from each other. So if we can really partner, and if you're not taking it, tell me why, so that we can work together on a different plan. And so this is a slide that, like I said, demonstrates, if you look at the left-hand side, you've got antidepressant adverse effects. So nausea, headaches, diarrhea, constipation. And then you've got depressive symptoms on the right: depressed mood, anhedonious, hopeless, helpless, tearfulness. And then in the middle there, you have things that could be either. So when we look at treating depression and a person has appetite changes, I'm going to want to be real specific about, did the appetite change happen when we started this medication, or had you had some of that before with the depression? So getting real specific on these things is going to be important, but you can see how it could be confusing sometimes, and why we have to use a little bit of trial and error to address these things. And so just being open and honest that, you know, I don't have the answer, because it could have been one or multiple of these things. And also you have a human body and it does different things sometimes. And so let's be mindful of this and make sure we figure out what to do.
Oh, special.
All right, there we go.
Someone's having fun.
So another thing to look at is to recognize the natural course of an illness. You know, so most things didn't start overnight and aren't going to become fixed overnight with medications. So we really want to be careful with that. We want to look at the effects of discontinuing previous medications and how that might play a role. Interactions between medications, you know, particularly if someone has a lot of comorbid medical conditions, we want to be mindful of those things. And then also considering, you know, if people are not taking the medication normally, what their other medical conditions are, and the presence of substance use. So for an example, if we're trying to help a person who's experiencing psychosis with a medication that's going to bring the psychosis down, using marijuana is going to pop that dopamine back up. So really helping to educate people on that's going to be helpful. So things we want to consider: changing only one thing at a time. You know, if we change 4 medications today and you have an adverse side effect, I don't know which one it was. So really doing one thing at a time is going to be important. You want to allow those medications to reach steady state before forming a conclusion. So that's why it's important to educate about when do we actually expect that we'll see something, and to set up the expectation, like for an antidepressant, and it's going to take about 4 to 6 weeks. So don't have the expectation that things are going to be great 1 week from starting. And then you want to really methodically track symptoms and side effects. You know, having somebody write it down, what they're experiencing, rating things can be really helpful in accessing the medications and how they're doing. And then you also want to inquire about missed medications, like I said, in an inquisitive, non-judgmental manner. Don't take medication treatment for granted or routinely assume it's absent. So just really ask about that.
We had a question: how often is lab work done? Is there a regular schedule for all patients, or is it related to the medication you're on?
So yeah, so we definitely want to get lab work the very first time we meet somebody, if we can get it there from a primary care, and then it's going to be dependent on the medication that the person's on. I mean, typically we're getting it at least yearly, if not twice a year. But also depending on if we're titrating a medication that has a level to it or has an effect maybe on the liver or on the kidneys, we're going to more routinely monitor it.
Okay. Another one, have you heard about GeneSight? Does it let you know about one's DNA, and is it compatible with certain medications or not? If they have a probability of working with your genome?
Yeah, and so I looked into this a few years back, these different sites that you can swab your cheek, and they say, you know, they'll say these medications may or may not work better for you. I'll be honest, the science on it isn't as far as we want it to be yet. And in my experience of using it, it's kind of hit or miss. It may say that a person metabolizes a medication way too fast and doesn't work, and that I found that that's the only medication that works for that person. I've found other times that I've used it that it has been helpful. So I think we're just not quite there yet with those things. It's a great guideline, and I hope someday that, you know, the first time a person gets treatment, that they would be able to we'd have that information in front of us. Would be fantastic.
Great, thank you.
Mm-hmm. Other things we want to look about with the medications and adverse effects: could virtually any side effect happen with the drug at any time, right? So there's a huge laundry list when you pick up the bag of medications from the pharmacy. So really, I ask people not to pay too much attention to the, you know, long list, because they have to report any side effects from those clinical trials. But understanding we also have a human body, and you're going to be paying more attention to that when you start a new medication. So we just want to look at that. Coincidences too, you know, do you always have a headache around monsoon time, and you also started a medication that has headaches as a side effect? Let's look at those things. And then there's certain things that people, particularly if folks aren't real interested in treatment, they may come to you with a fairly implausible side effect. Like, let's say, you know, the Seroquel gave me left toenail pain, and you know, it kind of surprises me, because I'm like, that's not anything I've ever heard or read, and I don't want to invalidate what the person is experiencing. For them, that there's a correlation there. So just reassuring the person it's not something that we typically see, that we'll keep monitoring it and make sure that they stay healthy, and that we address all of their concerns.
Okay.
So another thing that's interesting for psychiatrists is, so how the medications are studied for evidence-based research can be challenging to apply to real world people, right? Because all of these trials that are FDA approved are done in a perfect setting, highly idealized. People are only there with one medical condition, and they get one medication, and they're not using any substances. They're not taking anything else. So it's really hard to generalize to a community setting where you're going to have a lot of other factors. And those regulations are looking at an acute episode of an illness, not necessarily more longer term or low-lying symptomatology. So they're definitely a guide, but definitely we use our experience as psychiatrists for that. Also things that we see, you know, sometimes adverse effects that are seen in those trials that are low, we see a lot more often in actual real-world practice. So it's something you just talk with folks about and say, you know, it's something that I see a lot, you know, and I hear a lot from people. So one thing would be like sexual dysfunction with antidepressant medications. We see it more, and people experience it more than we see in the actual trials.
Mm-hmm. Okay, we had a couple other questions. One, what's your thought about melatonin to help people sleep, and can it be used to reduce anxiety?
So yeah, melatonin is a great natural agent to help sleep. So it's a great medication. As far as anxiety, I've not seen much help with that personally.
Okay. And another one, this was kind of a statement that it appears that people entering a psych hospital, especially a psychiatric crisis hospital, they have a kind of a cocktail to calm everyone down. And the person is saying, without even checking if there are known allergies, how do you prevent that from happening? And it happened even though they were guardians. So is there a normal cocktail if someone's really wildly psychotic and they appear?
Yeah, and so there's a couple of different cocktails, and we really try to do the best we can with the information we can with the scenario that's happening. You know, if we've got somebody that's, you know, assaulting people left and right and isn't giving us any information, we have to do what's best to keep people around the person safe and them safe, because them being exposed to that mania and psychosis, it puts their brain at risk. And so oftentimes we'll use a combination of an antipsychotic medication, a benzodiazepine, which would be like a sedating medication, and then a Benadryl, which would help calm things and maybe give the person a little bit of rest. So very commonly, a group of those medications will be given as an injectable form. Of course, if we have time to get information and ask about all of those things, but there are times that we have to act fast for the safety of the person and the staff. We always want more information, but we have to base it on the situation.
Thank you.
Mm-hmm. So in looking at our risk-benefit analysis for medications, we want to use shared decision-making. We're the experts in this type of care. The person is the expert in what they're experiencing and what has happened with medications prior to that. We want to apply the principles of person-centered care so that we really figure out what is motivating the person to get treatment. It may not be to find the right medication, it's to get back to work or get back to school, something like that. So how can we use the medications to adjunct your goals in life? We want to have recovery principles and give everyone hope that they will get better. And sometimes when people don't have that hope, we have to hold it for them until they get there. We have to know about our known and unknown risks. We also have to look at the watchful waiting of when is the right time to change the medications, and when to pursue other things and when to switch. You know, it's never a good idea to switch medication when you just moved into a new place, you have a new relationship, you just started a new job, and you have a bunch of stressors. That's not the right time, right? Let's wait till things are steady and talk about those things. So we really have to know that person's own treatment as well as their family members' treatment, because it may be like, hey, you know, my mom had really good luck for her anxiety and depression with Zoloft, so let's try that, because commonly people and families can have similar reactions to medication.
Along those same lines, a question, are some medications more suitable than others for patients who are very inconsistent in taking medications, in addition to periodic injections?
Yeah, and so things we would look at, we'll talk about a slide about long-acting injectables being an option for that. There are some extended release forms of medications that we use as well. And then there are some medications that are incredibly dangerous that if a person doesn't take them consistently, and so we have to stop prescribing them. So there's a real balancing act for all of those.
Thank you.
So the next thing is, this is the list of medication topics that we're going to go over. So antidepressants, anti-anxiety medications, stimulants, antipsychotics, mood stabilizers, and medications to address side effects. And then we'll talk about some special populations after that. So I'll go ahead and turn it over to Dr. Darling for antidepressants.
Thank you, Dr. Cowdery. I'm sure we'll have a few more for you, and welcome,
Sure.
Dr. Darling.
Hi, Beth Darling. Thank you guys all and for the wonderful introduction. I am the medical director here at the ACT program for Valleywise. And as Lori mentioned, both Dr. Cowdery and I have been working in the REBA for many, many years prior to going to medical school. So we have lots of different experience from all perspectives. So I'm going to take us through the antidepressants, and hopefully this will help answer some of the questions I think we've received before and throughout. So antidepressants, obviously we commonly use them to treat depression, but they're also used very commonly.
Oops,
Is that me? Is that the feedback? Okay. Depression's obviously a very common reason we would use an antidepressant, but we also use them very commonly to treat anxiety, some pain disorders, some insomnia problems, sometimes in ADHD or attention deficit hyperactivity disorder, and there's some other reasons we may use them as well, but those are the most common. We're going to go through the most popular. This is definitely not an all-inclusive list of every antidepressant out there. That would be its own lecture on its own, and I'm sure everybody wants to get to some of the other medicines. But the most common group, probably our first line for most patients, is going to be our SSRIs, or selective serotonin reuptake inhibitors, that mostly focus on affecting the serotonin in our brain. Many of you have probably heard of these: Prozac, Paxil, Zoloft. Those are the trade names of the most commonly used.
I'm sorry.
No, thank you. Yeah, sorry. Thank you. My apologies. Sorry, I'm still at work. So we commonly start in this class of medicine because they're generally very well tolerated by most patients and have pretty good efficacy, which we'll see the efficacy, how well they work, is about the same among many of these classes. And so oftentimes we'll try to figure out which medicine to prescribe based on some of the nuanced differences between the medicines that we look at, and also what kind of side effects the person may tolerate versus not tolerate well. The next class we look at are the SNRIs. They're similar to our SSRIs, but these ones affect the norepinephrine, another chemical in our brain, as well as the serotonin. And probably the most common out there are Effexor and Cymbalta. The one bonus to these is they have been shown to be pretty effective in treatment of pain as well. So you'll sometimes see that if somebody has some neuropathic pain in addition to depression, this may be where their doctor leans first. Then we have our bupropion or Wellbutrin, which works on dopamine. So again, another chemical in our brain. So they all work a little bit differently. And a lot of times in my prescribing, I'll reach for this one if I have somebody who has a lot of sort of fatigue and lack of motivation and things like that, because it can be sort of stimulating a little bit for people and help give them a little bit of that energy. But when we give somebody energy, it can sometimes make them anxious. So I try not to use this first in my really anxious patient. There are also some other novel antidepressants. I think we sometimes use mirtazapine. It's not on here. But one of my favorite sort of side medicines that's not usually my first medicine, but can make people kind of sleepy and hungry. So if I have somebody that I work with that's not eating and not sleeping, it's sometimes a good place to go and can be a very effective antidepressant. So those are all our newer medicines. Those are sort of where we typically start with a patient, depending on what we're seeing. When I mentioned ADHD, when we're looking for a non-stimulant medicine, a lot of times we'll try something like bupropion or Wellbutrin. Some of you may have heard of the other name of Wellbutrin is Zyban. It's its other brand name that can help with smoking. So sometimes if that's somebody's goal, we'll look at Wellbutrin because it can help reduce the amount of smoking and craving for tobacco as well. So then we have our older antidepressants. We have our tricyclic antidepressants and our monoamine oxidase inhibitors, or MAOIs. These medicines are just as effective or sometimes even more effective than our newer medicine. The problem is they're also dirtier. We've gotten much better at making medicines that are cleaner and have better side effect profiles and better tolerated. But the older medicines hit tons of receptors in our brain, and so sometimes they can work better. But that means if we're touching a lot of stuff in our brain, we're getting a lot of effects. Some of those are good and some of them are bad. So they do tend to have a lot more side effects, and so we tend to reach for them later if somebody is struggling to have a good response to one of those first-line agents that I spoke about. There's lots of newer agents out there too that I didn't mention. Persique's one that I think that has had a lot of commercials. That fits into our SNRI category. It goes by the name desvenlafaxine, so it's sort of a sister or a cousin to Effexor. Spravato is that nasal spray of ketamine, and then you've probably seen a lot of those ketamine centers coming up and are like, what are those? How can that cure somebody tomorrow? And I hope that's true, but the science is still pretty early on a lot of those things. They're still very expensive. There's almost no coverage for insurance, so it's very hard to get those newer treatments, but there's a lot of really exciting up and coming research, I think, coming. I guess I'm always skeptical when somebody tells me something is the magic cure, because so far I've been let down when I believe that. But I always keep up hope, just like I try to do with my patients. And so I'm very open to seeing what's on the horizon for the ketamine and in the treatments like that.
Dr. Darling, I'm not sure if you're going to know this or it's more about the pharmacologist and the insurance boards, but how does the insurance determine which meds they add to the formulary? Is it more cost, or is it about the meds which have better results in studies, or both?
Very good question. And I know some of this, but probably not all the intricacies because I don't work for an insurance company. Many of the decisions are made based on cost, based on number of trials and efficacy data that's shown. most insurance companies, it's a little bit different for the Medicaid plans. So for those of you who are familiar with like the Mercy Care plans or the other access plans, those are very different than traditional commercial plans that tend to tier medications. Mercy Care does that sort of, but it's in a very different way. And so they do want to start with the less expensive, right? We always want to spend less money if we can. And then they will typically make some of the more expensive medications available with higher copays or with prior authorization if we failed some other medicines that tend to have decent efficacy shown. And then in the hospitals with like formularies, that's part of that is contracting with various different pharmaceutical manufacturers as well.
So basically, if it's really expensive, you're going to fail first.
A lot of times, unless it's a novel medicine and there's nothing else like it. So sometimes, and we don't see that as much in psychiatry as we do in other parts of medicine. We don't have any monoclonal antibodies or any of those new biologics that are out there, but a lot of those sort of branded, really expensive medicines for other conditions, you can get those without failing some other treatments if there's no other treatment. But because we do have other treatments, they will typically want you to fail or not have a full, robust response on something that is less expensive first before we move on to a more expensive agent.
Okay.
Okay, so how do we do with antidepressants? They all work about as good as each other. So there's a whole bunch of them. How do I pick? I pick based on a lot of different things. A lot of them have varying different properties, like some make you more sleepy, some make you feel more awake. Some last longer in your system, so I know you're not going to take your meds every day, so I need to give you something that's not going to wear off after 12 hours. And so those are the kinds of things that can clue me into which direction we go. Dr. Cowdery had mentioned family history. If your mom and your brother and your cousin have all done amazing on Zoloft, I'm probably going to try Zoloft first because everybody else has done amazing on that. So let's give that our first shot, and then we can always adjust from there. There's not good understanding of why people respond better to some antidepressants than others. Dr. Cowdery touched on this as well. The genetic testing, I think when that first came out, we were all hoping that was going to be the magical answer for this. And unfortunately, it hasn't been really. The science hasn't really supported it as much as we would have liked. So I'm hopeful that we will make progress on that it's really in its infancy and that we will have better ways to tell. But for right now, it's really the art and science of understanding how the medicines typically work in the typical patient and what does the person sitting in front of me look like and what do they want to look like and how do I match those two things together. It's important to understand that the medicine takes a little while to work. So it's not like they're going to go home and take their pill and be like, what the heck, Dr. Darling, I'm not better. And it's Tuesday and I just started Monday. So I really try to make sure when I'm meeting with somebody that we talk about the expectations. It's going to take 4 to 6 weeks. It's going to take us some time to get you to the right dose because I don't want you to have a lot of side effects. And in order to avoid that, I have to go up slowly on the dose. And that we need to be sort of patient if we really want to give this medicine a good try. And I think when we set people up with that expectation, they tend to be more patient in general. And people do find, I think, especially with the antidepressants, but also the antipsychotics, that the medicines help. They say, oh, this worked great for me for 5 years, and now all of a sudden it isn't. And that does happen, and there can be various reasons why. So we always work with our patients to help come up with a new solution.
One quick question.
Of course.
What is your opinion about medical marijuana with someone with psychiatric illness?
So I think it's sort of a tricky question because I think it's different for each person. In general, as a psychiatrist, I don't recommend medical marijuana. It typically, for most people, is a depressant and can cause psychosis for people. And so it will oftentimes worsen the symptoms, but there are lots of people who will tell you subjectively it makes them feel better. It helps me calm down. It makes my anxiety better. But what I would say is a lot of those types of responses tend to be sort of short term, and then we end up with more depression, more motivation problems, potentially more psychosis if psychosis was an issue. So in general, I don't see a great medical indication for medical marijuana in psychiatry at the moment. Although I'm sure there's plenty of people that would disagree with that. But I think, you know, it's like the other things, the studies for that are really in their infancy. And I certainly look forward to, as we learn more about marijuana and different strains of marijuana and how they affect you, to seeing the future research on that.
Is that your same opinion on the new studies at Hopkins on microdosing psychedelics?
Yeah, I'm really excited to see them. I think it's really interesting and exciting, and I love when a big university picks something up like that, because it makes you go, well, there must be something to it. Let's find out what it is. So again, I think it's really in its infancy, but I'm excited. I'm excited for anything that's going to help make mental illness for people and their experience better and get people well and back to their lives. So, you know, I'm not biased against anything. I'm willing to read the research on anything.
Thank you.
Okay. So we talked about this a little bit already, that it often takes about 4 to 6 weeks at a full dose to really decide if something is going to be effective. With any medication, not just antidepressants, it's always best for somebody to let me know, okay, this isn't working. I don't want to take this. It's making me too sick, and work with me to take them off of it. Some medications, even if they're not necessarily like addictive or habit forming, they can have some unpleasant consequences if you just stop them suddenly. And antidepressants are no different. Sometimes people will explain having like a headache or even like a flu-like syndrome from stopping their medication suddenly. So it's always best to be honest with the doctor and work with them to go off the medicine or change the medication. A lot of times this happens, somebody will take medicine and they feel all better and they don't need it anymore. They're cured. And I wish that was true. In psychiatry, we don't have anything yet that is a cure. Most of our treatments require long-term treatment, although there's times that people can come off of medications. It typically, if we do it too soon and we do it too quickly, we can see a return in symptoms. So you definitely want to follow the doctor's guidance on that. And we talked about this, antidepressants are not addicting, they're not habit forming. Your body doesn't become reliant on them to exist or anything like that. So there's no worries about getting addicted to any of the medicines we've discussed so far. Possible side effects, the most common far and away, especially of the SSRIs and the SNRIs, are nausea and vomiting. Typically, I'll start my patients at a really nice low dose and go up really slow. And that tends to help mitigate that as much as possible. And people get frustrated with that sometimes because they're like, I want the biggest dose and I want to be there right away. And then when we talk about, hey, it's going to take 4 to 6 weeks anyway, we might as well not make you nauseous on the way. They typically will go slow with me, but typically that's very self-limited, usually about 3 to 5 days. And then for most people that goes away. If it persists, then that may not be the right medication for that person. Some of them have weight gain. It tends to be fairly minimal, except for mirtazapine, which does have a fairly significant association with weight gain. Diarrhea can be common. So can constipation though, so that's also confusing. You know, it's hard to get both at the same time, but it happens for people. Sleepiness, some people can get sedated, but also some of the medicines can sort of wake you up a little bit. So it depends again on the medicine. And sexual side effects are a fairly common side effect. So that's one of the ones I always make sure I counsel patients on, because people get really you know, awkward and uncomfortable in talking to their doctor about it. So if I bring up conversation first, I think it always leaves the door open for people to come and talk to me about it. The most concerning thing we worry about in antidepressants is serotonin syndrome, which is essentially too much serotonin. And so we worry about that if we use too many of these things at once. So we really only want somebody on one SSRI or one SNRI, and we can, if they need an adjunct, like something's working mostly but not all the way, we can use a different type of medicine. It can also happen if we mix SSRIs and SNRIs with some of our medical medications like triptans, which is what we use for migraine headaches, like sumatriptan, or other things that increase the serotonin, like certain pain medicines like tramadol. So we just want to be careful that whatever doctor's prescribing you or your loved one any medication, that they know all the medications. Serotonin syndrome is very rare when we use our newer antidepressants. That's why we stick with those first, like our SSRIs and SNRIs. It was much more common when we were using medicines like MAOIs, which have a little bit stronger action on that serotonin. There is a black box warning on most of the antidepressants regarding an increase in suicidal thoughts. That has been found to be significantly worse in our younger folks, 18 to 24. That's where the real significant problem was noticed. Although as further studies have come out, what we've noticed is that while initially some people will have an increase in suicidal thoughts, the actual completed suicides of patients who are taking antidepressant medications are far less than those who are untreated. So while there is a risk of increasing typically at the beginning of treatment for a short period of time, some of that suicidal thinking, which is always really scary. People are like, why are you putting me on this medicine if it's going to make me suicidal? I'm trying to be on a medicine so I'm not suicidal. The reality is they are much less likely to complete a suicide if their depression is adequately treated. And so we do want to do that, but we want to caution people, and we want to have them call us right away or call their team or call their family or whoever, their suicide hotline, if they're having any worsening of those suicidal thoughts, so that they can get some support through that.
Okay.
All right, this is Alicia again. We're going to switch over to anti-anxiety medications. So there's a variety of medications that we use to treat anxiety, and those might be different things that people experience, such as panic attacks, extreme fear, worry, lots of physical things people might experience like shortness of breath, tingly sensations, things like that. And so we want to start with some medications that can help in a short period of time, because the other medications we use take a little bit longer. And as you can imagine, if you're having a panic attack, having something that acts pretty quickly can be helpful. We want to use these as needed medications, and these are benzodiazepines, or you may have heard benzos as they're commonly called in the community. So we use those as a first line for severe symptoms of anxiety if we need to treat things very quickly. They're also second line for panic disorder, social phobias. So the common medications you might hear are like Klonopin, Xanax, or Ativan. Those can be used, and we tend to use these in a pretty controlled environment where we know that the medications would be used correctly. They do have a potential for abuse and a potential for worsening substance use disorders. So we have to be really careful with who we're prescribing these medications to, the education we provide about them, and also how people use them, because they're also people can divert them and sell these medications as well. So we check these medications very closely to make sure we have something that's a controlled substances monitoring program, so we can see if anybody is being prescribed any of these medications, so that we know that folks aren't, kind of doctor shopping around or abusing these medications. So we're very careful with these medications. Beta blockers are also used, so that is a medication that would be used for a high heart rate, and so commonly it's used for anxiety. People are trembling, they have a rapid heartbeat, sweating, or phobias in specific situations. I know we definitely prescribe people for if they're doing public speaking and they need a little bit of help to calm down. It's common that we might prescribe one of these medications, like a metoprolol or a propanolol.
Now, we had a question come in. I'm not sure whether it's going to be better for you or Dr. Darling. What about using an SSRI with Lamictal, mood stabilizer? Is that contraindicated or not? Not contraindicated. Or you don't?
Do you want me to answer it? We commonly use an SSRI with a mood stabilizer. It's not an uncommon thing to do. I'll talk a little bit more about it too when we get to the bipolar section, but there's no safety concern necessarily in that combination.
Thank you.
So as we talked about, the benzos are effective for relieving anxiety and act quickly, more quickly than the other antidepressants that Dr. Darling talked about, or buspirone, which we'll talk about. It can take some time. So we commonly might prescribe benzodiazepines for a few weeks to help things calm down as an antidepressant or anti-anxiety medication. Like a Zoloft or Prozac is also added on there. So it buys us a little time to help that person with their anxiety, but also get the other medication on board. That's going to be a little bit more effective at that. People can build up a tolerance over time, and so some people have to be on higher and higher doses, which is why it's important. You know, in our practice, we are pretty conservative with these medications and stick to this is going to be a short-term medication for folks so that we don't have to keep building up a higher and higher tolerance. We want to use the best medications. And people can become dependent on them, and it can be hard to come off of them. So education up front about these medications is really important. And then, you know, if you do get a person that's been on long-term benzodiazepines that comes to your practice and they've been on them, you know, taking some time to figure out how to taper down on those if it's the right thing to do. We also, like I said, want to be careful with people with substance use issues, older adults, and people who become dependent on medication. A person that, you know, needs to solve something right now and turns to a medication instead of using maybe a coping skill or something like that. So those are folks we want to be careful about. And if people suddenly stop, they can have a withdrawal symptoms. So we really want to be careful to not have people stop suddenly and that we taper the medication slowly.
Okay, we had a question. What are your thoughts about whether benzos enable anxiety? For example, if the client learns to cope, they'd eventually be able to function a lot more at work, or is it more individual?
Yeah, I think it's going to be a delicate balance for people. So getting to know people and how they deal with things is going to be really important. We don't want to create a dependency or anything like that. We want to use medications to help people in the anxiety time that they're having, but there may be indications where the benzo is not the right choice, and that's the other choices that we'll have on our next couple slides.
Okay.
So buspirone or Buspar is a medication that helps with chronic anxiety. It's a medication you have to take every day, and it takes a couple of weeks for it to get to a full effect. It's not useful as an as-needed medication. We oftentimes use hydroxyzine or Vistaril, which is like a cousin of Benadryl. It's an antihistamine. Also is used for sleep, but it can be used regularly or as needed. Trazodone, which you've probably heard of for sleep, small doses are often used for anxiety in older adults, and that can be used regularly or as needed. Gabapentin, Neurontin, which is the medication most commonly used in diabetic neuropathy. There's been some studies that can help with anxiety when taken regularly, so that's the medication we use. And then, as I talked about at the beginning, all the SSRIs, SNRIs, and bupropion have some efficacy with anxiety. So based on a person's own profile, we might look to those medications. So common side effects, so nausea, blurry vision, headaches, confusion, tiredness, nightmares. We want to be really careful if people are really drowsy, dizzy, unsteady, they have trouble with coordination, thinking or remembering things, or having any difficulty breathing. So it's going to be really important to educate about those things. They're not all that common, but you want to look out for them because everybody's body is going to react a little bit different. You know, some people have a really high tolerance for medication and some people don't. So the beta blockers I talked about that people may take, we want to be careful in those with people who have asthma or diabetes because they could worsen those things. Sometimes they can cause fatigue or cold hands, dizziness, weakness. And then with the Buspar or the buspirone, because it has similar things to the first slide, it can be activating for some people, so they might have a little bit of trouble sleeping. I'll turn it over to Dr. Darling for stimulants.
Okay, stimulants. So typically we're going to see stimulants most commonly in ADHD or attention deficit hyperactivity disorder. They cause increased alertness, attention, they can increase the energy, but they also have a lot of physiologic effects as well, including the blood pressure, heart rate, and respirations. There are several different classes. The most common ones are listed here. So you have your methylphenidate, those are your Ritalins, and they all come in sort of short-acting to long-acting versions. We have amphetamine salts, which are your Adderall products. We have dextroamphetamine, which is dexedrine, not used probably nearly as much as the others. And then lisdexamphetamine, which is probably our newest one, 5-ants, which is a long-acting and can be very effective. A lot of times when we're working on starting somebody on a stimulant, we'll start them on the immediate release, see how they do with it, see how much they're needing, and then we'll convert them over time to the long-acting medications. There are some non-stimulant medications that are out there as well. We will use the antihypertensive medicines like clonidine and guanfacine, and then those are all Catapres and Catve and Tenix and Intuniv are all the brand name versions for those. They are technically antihypertensive medicines, so we have to watch blood pressures, making sure they're not coming down too far and making people feel dizzy or lightheaded. But they can be very effective, particularly in the hyperactivity and impulsivity types of symptoms that we'll see sometimes in ADHD. They can also help mitigate some of the insomnia and things that we can see with our stimulant medication. So sometimes somebody will take a stimulant in the morning and one of the antihypertensive medications at nighttime to help sort of settle them down and be able to rest at nighttime. We can also use atomoxetine, which is a non-stimulant medication, typically considered a second line, and has some good efficacy for some people. The most effective treatment for ADHD is going to be our stimulants. Stimulants are also used occasionally for other things like narcolepsy. Sometimes they'll be used in like shift work sleep disorders where people are working night shift and they just cannot get up and get moving during the day, but that's much less common. Sometimes they'll use them in depression or post-stroke if we're trying to get somebody up and doing things, or like participating in therapy if they've had a pretty profound stroke. But those are all much less common reasons. The most common is going to be ADHD. Okay.
We had a couple. One, do you see differences between branded or generic medications? Is that?
Yeah, so technically all generic medications have to have the same active ingredients as the branded medications. So in theory, they should all be the same. And typically we do use mostly generic medications for cost because many of our payers aren't going to pay for the branded version of a medication if there is a generic available. But I have had patients who tell me if I, even just between the different generics, if I take this brand of a generic versus that brand of a generic, I get headaches. And, you know, if somebody tells me that's what they're experiencing, then I'm sure that's what they're experiencing. But as far as efficacy, I haven't typically noticed a major difference.
And we had another, what is the highest dose of Klonopin that one can safely take?
That's a tricky question because benzodiazepines can be used, like Dr. Cowdery mentioned, for a number of things. People grow tolerant to them. So if you've never taken Klonopin, even 1 or 2 milligrams may be too much for you and could cause pretty profound sedation. But if you've been taking 2 milligrams a day, then 4 milligrams a day, you're going to be really tolerant to that, and you're going to be able to tolerate a much higher dose of that over time. There's technically, with benzodiazepines, they were sort of created when barbiturates were around and used sort of back in the day to help with anxiety, like phenobarb and pentobarbital and things like that were really commonly used. And then it turns out they weren't that safe and people were accidentally overdosing all the time. And benzodiazepines were sort of created to try to solve that problem, and they actually have a fairly high therapeutic window where you could take a lot and it would be pretty hard. You would get sick and you would, you know, probably lose consciousness and things like that if you took a ton, but you have to take a lot for that to happen. But I would say there's not like a number I would say is safe. Every patient is totally different and what their tolerance is very different.
Okay, and we have one on, is there a reason that caffeine isn't used more as a stimulant?
It's very hard to regulate in general. I guess you could use the caffeine pills. My caution always with stuff that's over the counter is that we don't always know what's in our sort of over the counter supplements. I mean, I think a lot of people, probably most Americans, use caffeine as a stimulant. So many people can't function without their coffee or whatever they use as caffeine in the morning. Caffeine has a fairly short half-life, so it wouldn't be great compared to the stimulants that we use to treat ADHD. Most of those have much longer half-lives and can provide a full day of efficacy. I don't know if anybody's ever noticed when their morning coffee wears off, it's typically not right before they want to go to bed. There's typically a time earlier than that, so it really doesn't last all day.
Thank you.
All right, back to stimulants. So when you have ADHD and your brain goes from topic to topic to topic, stimulants can really help to focus you on one thing at a time, which is obviously the most effective way to do things. And they are very safe to use under a doctor's order. We often talk about using them in children. That is the most common time we see them at least initiated for people is ADHD in children. And kids are funny on how they respond to it. Sometimes they'll tell you they're feeling a little dizzy or a little funny, or I feel different. I can actually sit in my chair. I don't need to spin around and around and around, that kind of thing. A lot of parents worry, oh my gosh, I'm starting my kid on a controlled substance, or we call it amphetamine salts, and they're like, I'm starting my kid on meth, and they get really scared. And you're not. We're starting them on a controlled substance. That's true, and it does have abuse potential, particularly if people don't need them. But a lot of the studies have shown that if we have significant ADHD that's causing disruption, whether it's in social emotional development or in school or other various areas of growing up, and we don't treat it, that actually significantly increases the risk of substance use down the line, as opposed to using a substance in a safe, controlled manner where the child gets to see, okay, my doctor knows me, they gave me this prescription, I'm supposed to take this dose at this time, and we always follow sort of the doctor's guidelines. We can sort of set them up for this is how we do it, and we get the benefit out of doing it this way. And also because they are medicated and they're doing better in their life and functioning better in school and functioning better socially, there's less of that, I need to find something to make it better on my own on the streets. So a lot of the research really supports that treatment of ADHD is a really important thing to do in childhood.
Okay. And there was one about someone's been told ADHD meds cannot be taken along with Abilify or Lamictal.
I mean, that's inherently, there's no problem mixing stimulants with Abilify or Lamictal. There's probably more problem mixing stimulants with bipolar disorder or psychosis, because stimulants are definitely problematic in both of those conditions for people. Always, it's important to individualize the treatment and make sure that that makes sense for that particular person. But there's no specific drug interaction between those drugs per se, but there's definitely problems in using stimulants with people who could become manic or people who can become psychotic, as it can potentiate those symptoms.
Okay. We have one other related to that. Are doctors usually resistant to prescribe medications to adults with ADD or ADHD if they've never been medicated before and have been using caffeine instead? Is there an ingredient in black tea that helps with concentration better than coffee?
I do not know the ingredients of tea and coffee well enough, or the milligrams of caffeine, to comment on that. I think there are lots of doctors who are hesitant in using stimulants, particularly if they don't see a lot of children, because that's a big part of the child and adolescent population, is the treatment of ADHD. Adult onset ADHD is much less common in general, and so I think that makes adult psychiatrists sometimes concerned, especially if you're a doctor that's more used to working in the SMI population, where on my ACT team, most of my patients, a stimulant would be a really bad choice because it would potentially worsen a lot of their psychosis, which is mostly what I treat, and it would potentially worsen their mania and things like that if that's something they experience. So when you see doctors that are in the SMI system like me, there, you do see a lot of hesitation to that because we can see a lot of bad outcomes with those folks. In the more well population, if you're getting seen by a private psychiatrist for ADHD specifically, and you have no concerns about substance use, and you can sort of demonstrate a history, and they find that you're diagnosed with ADHD, I think most psychiatrists will treat that as they see fit.
Okay, thank you.
Possible side effects. Well, stimulants stimulate you, so those are the expected side effects. It can cause problems falling asleep. It can cause you to have a decreased appetite or even weight loss. Some people do experience an upset stomach or headaches. And less commonly in kids, we can, or I guess adults too, I just happen to see this more commonly with kids with ADHD, you can see some motor or verbal tics present or even worsen if they had them prior. And some people say that they feel like it sort of blunts their emotions. They sort of are flat and don't have as much emotion.
All right, it's Alicia Cowdery again. I'm going to switch over to antipsychotic medications. So antipsychotic medications are primarily used to treat psychosis. We're going to use them to relieve symptoms and improve quality of life for folks that may be hearing voices or experiencing paranoia or changes to reality around them. And those things can be a symptom of substance use. You know, there's the methamphetamines, cannabis, cocaine, those things can cause that. Or they could be from a mental health condition, such as schizophrenia, bipolar disorder, or very severe depression. So these medications are used for a few other things as well. They may be used to treat a delirium and when a person's in an ICU, dementia, and then other things we adjunct on at times. ADHD, severe depression, eating disorders, PTSD, OCD, or generalized anxiety. But these are going to be after we've tried all of the first and second and third and fourth line medications for those things, primarily schizophrenia, bipolar disorder, and psychosis. So you may have heard of the different names of them. So the initial ones are older first generation medications, often called typical antipsychotics or neuroleptics. So common names you might hear are Thorazine, Haldol, Trilofan, Prolixin. And then our newer medications are listed on the right. So there are second generation or atypical antipsychotics. So Risperdal, Zyprexa, Seroquel, Geodon, Abilify, Invega, Latuda, Clozaril. These are the most common ones that we use. It's not an exhaustive list here, but what we most commonly prescribe. So how these medications work. So these work a little faster than some of the other medications. Things that people feel as far as like agitation or auditory or visual hallucinations can go away a lot quicker within a couple of days of starting these antipsychotic medications. Things that take longer are things like delusions. Those are take a little bit more time to really hold, and depending on the medication. And then every person is going to respond differently. So it may take several trials. So this can be frustrating for the person and their family. Again, we try to take into account some family history, the person's own medical history, and different things that they're experiencing to choose the right medication. You know, if a person's not sleeping that well, let's use a more sedating medication. If a person has low energy, let's use one of the medications that might give them a little bit of energy. And so it's really an art with all of the antipsychotics to figure out what medication works for people. People can always have relapses. It generally happens when people stop taking the medications or when they take it sporadically. These are medications, if you take them orally, need to be taken every single day at about the same time of day regularly to really maintain a steady state in the body. And just as with the antidepressants that Dr. Darling talked about, some people stop taking them because they feel better. All of a sudden, you know, I don't have this bothersome paranoia and I don't have these voices, so I must be fine. Let's stop taking it. And things can come back really fast. So we always encourage people to not stop taking medications on their own, that they really need to talk to their doctor if there's going to be a tapering plan. And we never want to cold turkey stop something, because we really want to weigh the risks and benefits of stopping an antipsychotic medication. These medications aren't prescribed, just, casually. We know a person has experienced psychosis, which is a very serious condition, and we need to make sure that we treat it and that we manage it, because people can have significant declines in their life if they experience another psychotic episode. We want to protect that brain so that it's protected from that excess dopamine that's causing the psychosis. And we really want to make sure that we don't put the person in danger of going back to the hospital, being involved in the legal system, losing their current job. So we really want to be very careful in tapering and very mindful with a watchful program where we take into account the person's own support system and a relapse prevention plan with designated observers that can help us monitor how things go as we taper off those medications.
So Dr. Kennedy, you mentioned that, oops, something's going on. But you mentioned that, I don't know what's going on. You mentioned that you want to prevent them going to psychosis. Does that mean that if they're in and out of psychosis a lot or often or many times, does that have long-term impacts?
Yeah, definitely. And that kind of, it speaks to the work that we do at our first episode center. It was where we try to get people at the very beginning, the first time they experience psychosis or schizophrenia, because every time that brain is exposed to excess dopamine, you get worsening cognitive functioning, as well as just functioning for life. So if we can just have one episode and we get better, people stay on track and get back to work and school and life. The more psychotic episodes, the worsening it is for your brain and how you're going to do long term. So as often as we can prevent that, the better it's going to be for the person and their brain health moving forward.
Okay. Now, we have a couple on anosognosia. How do you address patients with that if they don't have insight? There isn't a magic pill, right? Or is it?
Anosognosia and insight are a little bit different things. So I think what we're going after is insight. Yeah, it's really hard with insight for things, particularly people who experience psychosis, is because, they don't experience that they have changed. The world around them has changed. You guys work for the FBI, that white van is outside. It's not me. The world has changed. So it's really trying to partner with the person what on their goal is their goal may be to, let's say, get a girlfriend, and I say, okay, so what's preventing you from getting a girlfriend? Because they're like, I don't have schizophrenia, I don't need this Risperdal. Like, well, I don't have a girlfriend because my car's broke down, I can't take anyone out on a date. Okay, why's your car broke down? Well, I don't have money to fix it because I don't get as many hours at work. Okay, why don't you get as many hours at work? My boss says I'm talking to myself and I'm not as effective as I could be. There we go. So if we had something that could help you be more effective at work, if there was something we could do with that, then maybe you could ask a girl out on a date. So it's really partnering with the person to find out what their motivation is and working with that. It's not, the goal is not to get somebody to say, like, I have schizophrenia, I love Risperdal. We want them back to functioning in their life. So if you can partner that way, you'll get a lot better outcomes.
Thank you.
Mm-hmm.
We have some questions on stimulants, but I don't know whether you want to wait and then go through this and go back to the stimulants.
Yeah, I think it might be good for us to make through, because I want to make sure we get through all of our info. So long-acting injectables medication. So folks have probably heard of these. And so these are options outside of an oral daily medication, and they have really great results. And in Dr. Darling and I's practice, we prescribe a ton of long-acting injectables just because we see how well they work. They really help the medication stay steady in the body better, because you don't have to take a pill every day or forget and those kind of things. So I like to present these medications, which is not commonly how they're presented in psychiatry. They can be presented as a punishment because you can't remember to take your medications. I present it incredibly different because we want to talk about options, just as a primary care doctor might talk about options for birth control. Would the best option for you to be a daily regimen, a monthly regimen, an every 2 to 3 month regimen? What fits with your lifestyle? And then talking about, okay, well, if you don't want to have to take a pill every day, or you don't want to have to remember to take them when you go on vacation, or you don't want your friends to see them, an injection works too. And we've got ones that can that can last up to 3 months at this time, and they're very well tolerated. People tend to have less side effects with these medications and just greater functional improvements. And so in our practice, this has been a beautiful, wonderful thing that we need more of these things. So we're big proponents of the long actings. You have your first generations, which are your older medications, which have a lot more side effects. So a Haldol deck or a Prolixin deck. And then you've got your second generations, which do really well. So Risperdal Consta, Zyprexa Prez, Invega Sustenna or Trenza, which is the 1 and the 3 month. Abilify Maintena and Aristata, which can go to multiple months. So these are the medications that we commonly use for long actings. So there are newer antipsychotic medications. They're not as widely used, and you can see the names of some of them here. It speaks to a little bit about what Dr. Darling talked about with earlier is, when they're still a brand name medication, they're extremely expensive. They're probably not going to be covered by the insurance unless you've had multiple failures of medications. So there's no generic form, so it makes it really pricey for folks to have these medications. And oftentimes people will say, oh, well, they give out samples, the drug reps give out samples, why don't we try that? And that's a really dangerous position to be in as a physician, because let's say I give you this medication and it from the drug rep and it tends to work, and then all of a sudden then your insurance won't cover it, and you and your family are now stuck with $1,000 bill a month. That's a really tough position to be in. So we want to make sure it's covered, or there's a way to pay for it before we even broach these things. But Dr. Darling and I will go to bat with insurance companies and do whatever we can to try to get these things covered. The hard part is with Medicaid plans and Medicare plans too, is that there's a level of access and the federal government that plays a role in those things as well. So there's many different side effects that people can have. Sometimes people feel tired, dizzy, they might feel restlessness, we talked about at the beginning, that akathisia, weight gain, and that's different for different antipsychotics. And again, we want to modify all those things, your exercise and nutrition with the weight gain. Dry mouth, constipation, some GI upset, blurry vision, lower blood pressure. People may have different movements, such as like a tic or a tremor. Those things are worse with some of the older medications, seizures, low white blood cells, for some of the medications. So we regularly monitor, weight, glucose, lipid levels, those type of things with labs to make sure that we check those things. So we also have to watch out what we call is EPS, or movement disorders. So people can be really rigid. They might feel really stiff, like I can't move my arm, it's stuck, or my muscles are rigid. They can have some muscle spasms that can be really uncomfortable. They might have tremors that are also uncomfortable, or that restlessness, that energy that they need to get out. And so we'll talk a little bit later about the medications that we use to help that. Oftentimes lowering the dose is the best thing to do of the medications to address those things, because maybe if we're having some efficacy of the medication, but some side effects, let's balance out that dose. And then a longer term issue that is fairly rare, but we always want to talk with people about, is tardive dyskinesia. So it's kind of like those movements, but in a more permanent form. A person might have like their tongue is moving around their mouth all the time and they can't control it, and it can be disturbing for folks. So there are a couple of medications that are out now to help.
You got the lights on just for.
Oops. Sorry about that. I muted them.
Okay. All right, we'll turn it back over. Do you want to do questions about antipsychotics before we go to?
So we did have one. Does psychosis and substance abuse in untreated or inconsistently treated patient cause permanent brain damage, or can that brain damage be reverted with treatment? Reversed, sorry.
So that's a complicated question to answer. So if we can prevent any of those episodes, we want to, right? And there's a stark difference if you looked at the patients that we see at our first episode center that are young kids, one episode, their cognition comes back really quickly and they do well once things balance out. If you look at folks that Dr. Darling sees in an ACT team who've been on many trials of medications, many times off of medications, chronic substance use, those are things that we have to work a lot harder with the medications to try to help. So people can become resistant to different types of treatment. We have to use higher doses of medications. We have to use combinations of medications. So anytime we can intervene early, think about anything that if you intervene early with, high blood pressure or a broken arm, if I wait a week to go to the emergency room for my broken arm, not going to have as much functioning if I wait a really long time. So in psychosis, it takes about 74 weeks for the onset of psychosis to an evidence-based treatment in America. And it's a really sad statistic that it takes that long for a person who is experiencing psychosis to get that treatment. So we really have to do a better job of identifying those things and intervening early and educating about protecting brain health.
And that there was a comment about that as well. It's the only disease that we wait till stage 4, right? We wait until
Right.
there's a psychotic break and then we go, okay, you know,
Exactly.
time to start treatment.
Yeah, that's the work that we try to do in the community to educate and try to intervene early so that that we don't have those issues. It's unfortunate where we are, but there is progress and there's national progress about those things. So there's hope for it.
And one before we go on, they were talking about, can antipsychotics be used to treat ADHD? They wanted to know if they read that right.
Yeah, sometimes they are used as an adjunct with ADHD. It would not be a first line, second line, but it might be an adjunct to help folks.
Okay. Okay, now mood stabilizers. Oh, one other thing I was going to say. I think I talked to you guys before. People that they co-medicate, they self-medicate while they're on antipsychotic medication, and they choose either meth or marijuana. I think you were saying we keep trying to counterbalance that, but meth always wins, right? It's a hard drug to fight, and it hurts the efficacy of the medications you're trying to provide. Do both marijuana and meth, is one worse than the other?
So that's hard because so much today we don't actually know what is in meth or marijuana, right? People are cooking these things in all sorts of interesting places, and we have no idea the actual content of them. In my experience, meth seems worse, depending on how potent the strain is, but there are strains of marijuana that are incredibly potent as well. And so that's why it's really important to educate people that if you've had an experience with psychosis, you already have an excess of dopamine in your brain. So we know that if we're pulling it down with the medications, and then you're using meth and those things, we're either going to have to continue to medicate or you're going to continue to experience the psychosis. And so it's a battle that's challenging, and it depends on where somebody is in their treatment. Are they on court order treatment and we have a little bit more room? Are they, willing to maybe pay attention or use less meth or marijuana? You really want to partner with people on those things.
And another one on antipsychotic meds. Why is clozaril only used as a last resort when it was considered the gold standard in treating schizophrenia?
So yeah, and clozaril is a complicated medication. It's a very good medication, and oftentimes psychiatrists aren't quick enough to go to clozaril. We should have a couple full trials, but because there are significant side effects that come along with medication, is that oftentimes we want to make sure we've tried every other thing that we could try, because for the person, you can imagine the experience is, I'm going to give you a medication, it's going to make you sedated. You are going to be drooling all the time. You're not going to kind of feel like yourself for a while. You have to get blood draws every week. You can imagine that doesn't sound super exciting to a person that might be experiencing schizophrenia. So really educating on that, it takes some time for the body to adjust and how this medication works. But a lot of times people and their families go back to their usual selves. It's the first time since experiencing any of that psychosis that they really truly feel like they got their loved one back or they felt like themselves. So it's a delicate balance because there are dangers to the medications that we have to be careful with, and it has to be monitored very closely. You can't use it in people that aren't going to take the medications reliably. It's one of those ones that is challenging if folks aren't going to take the medications regularly.
Yeah. We have one that borders on what antipsychotic or mood stabilizer meds have Parkinson or Parkinsonian symptoms as a potential side effect, and then how common is that?
So yeah, and most of them can do that, and particularly more so the older ones. And those are those things I talked about, the movement disorders and things like that. So they all have potential to do that. It's the older first generation medications that do that more commonly.
Okay, thank you. We can move on to mood stabilizers.
All right, so we're going to switch gears, but still hitting some of the same disorders. We typically will focus on bipolar disorder with mood stabilizers, although we can sometimes use them as adjuncts in major depression and some other places that we'll talk about a little bit. There are a couple common ones that we'll go through. Lithium is probably the gold standard in mood stabilizers, particularly, in acute mania. It's extremely effective. It's been around a long time and very well studied. And it can be very, very helpful in acute mania and also in the maintenance phase of the treatment of bipolar disorder. It has a really unique thing that's been noted about it in the literature, which is it does have some anti-suicidal benefits to it. So some of our folks with bipolar disorder who are chronically suicidal, this can be very effective. Or perhaps somebody with major depression with chronic suicidality who is not doing as well as they could on simply an SSRI will maybe add an adjunct of lithium, and a lot of times you'll see that suicidality drop, which is really, really beneficial, because that can be really scary for patients and their families. We also use a number of the anticonvulsant medications as mood stabilizers as well. Like lots of medicines in general, sometimes we design them for a reason and then we notice they happen to do other things, which can be really helpful. That's not just in psychiatry, it's all over medicine. And so anticonvulsants, many of them have been noticed, they're used to treat seizures, but it noticed that people were much more stable in their mood when they were taking them. And so we've taken a few of them into psychiatry and used them regularly. Depakote or valproic acid or any of these other names is probably our most common there. It is typically picked in acute, like mixed episodes of bipolar disorder where we have both some manic and depressive symptoms, or in our rapid cyclers. And we define a rapid cycling bipolar patient as somebody who has at least 4 episodes in 1 year. So they're people who are constantly having various different mood episodes. They have a totally different set of side effects from one another. They have lots of, so that'll be one of the things that we get to that we'll talk about, which will help me sometimes too in picking which medicine I may choose for a particular person. Other anticonvulsants that we also use are carbamazepine, which is also called Tegretol, or lamotrigine or Lamictal, which I know we've had quite a few questions on, and oxcarbazepine, which is like the cousin to carbamazepine, or Trileptal. I know there were some questions at the beginning about lab studies too. This is where our labs, we always do at least annual labs on all the other medicine. This is where sometimes we sort of have to beef that up, because a lot of these can have effects on various different organ systems and have therapeutic levels that we monitor with the blood. And I'll talk about that a little bit more as well. So mood stabilizers can have, a whole host, just like everything else, of side effects. They can, and these side effects do tend to be dose related. So the more we give you, the more risk you have of having these side effects. So typically, as Dr. Cowdery mentioned, our first line of treating side effects is if we can lower the dose and keep the person stable, then we will do that, because a lot of times that will resolve a lot of their side effects. People can have itching or rash. We tend to think about lamotrigine or Lamictal first here, but all of the anticonvulsants can cause that. Excessive thirst is going to be really seen with our lithium, and frequent urination as well. Tremor can be very common with lithium. Nausea and vomiting, some slurred speech, particularly if we're getting to those higher doses and people start to get a little bit confused. Fast, slow, or irregular heartbeats. Changes in vision, blackouts, which is not something I've seen unless the person really is toxic on the medicine, and same with hallucinations. It can affect the seizure threshold or rapid discontinuation, particularly of the anti-seizure medicines like the Depakote and the Tegretol, can lead to higher risk of having a seizure. We can also have some loss of coordination and some swelling, and sometimes. Most of these are pretty rare, I would say, with lithium. The most common thing that I see anecdotally in my clinic is the tremor, and unfortunately tremor seems to be one of those things that doesn't go away. A lot of our side effects, as people learn to tolerate the medicine, they improve over time and people get used to them, or they really do sort of disappear as the body gets used to them. But there are a few that once you got them, they're going to be there as long as you're on the medicine. And the tremor with lithium tends to be that. If you're someone that gets a tremor on lithium, you're probably going to have a tremor on lithium. We can do some things if it's really bothersome to try to make it better. But it's one of those things that if it's really bothering somebody and they cannot tolerate it, that's going to be one of those things we have to really change a medicine for. Okay, more side effects. Lithium, we want to check. So lithium is, most of our medicines get processed through either our liver or our kidneys, and most go through our liver. Lithium happens to be a unique one that happens to get processed more through our kidneys, and with time and with high levels over time can have some damaging effect on our kidneys. So we do monitor our kidney function very closely when somebody's on lithium. We also monitor their lithium level. Remember when we talked about benzos and somebody asked me, how high can you go on Klonopin? And I said, that's hard. There's not really a high ceiling if somebody's tolerant to the medicine. There's definitely a ceiling on lithium. It's very narrow therapeutic range, and somebody can become toxic fairly easily. So we need to have a fairly reliable patient if we're going to have lithium, and they need to be getting their labs so that we can monitor this, because that's when we're really going to potentially cause damage to the kidneys that we really want to avoid. So that's why we're always asking the patients or their families to bring them in for labs when they're on medicines like lithium, because we really want to make sure we're doing it as safely as possible. It affects, because it works through the kidneys, can affect sort of your urination, and it can affect your thirst and how we're processing water through our body. And so if it's really hot and we're sweating more, our lithium level can go up. So I'll always, especially in Arizona, be educating people on making sure if they're going to be outside that they're staying very hydrated, so that we keep their lithium level about where it should be.
Is there anything besides a blood test that a person taking lithium or their family or people around them can look for that can start to see a possible effect that they're dehydrated and they're getting toxic?
Yeah, so the very common early signs of lithium toxicity are going to be nausea, vomiting, confusion, sweating, and things like that. And then as it progresses, they may become increasingly more confused, really kind of out of it or delirious looking. So anytime somebody's on lithium and having new or worsening nausea or vomiting or headaches or changes in urination or confusion, we really want to take that seriously. Okay. I saw another question about the tremors. Sorry, I wasn't clear about that. They do go away. It's amazing. When you stop lithium, they go away, which is different than like the tardive dyskinesia that Dr. Cowdery talked about that can happen. The tremors that can happen that are more Parkinsonian with the antipsychotics, like the pill rolling tremor like this that you can see a lot of times that you see with a Parkinsonian patient, those tend to get better if we go down on the medicine or switch the medicine. They don't always go away, but those tardive dyskinesia movements in the mouth and the tongue, or sometimes like in the back and things like that, those tend to be more permanent, unfortunately. If we catch it early and take people off the offending agent, we can sometimes reverse it. But otherwise, those tend to be more permanent. But luckily, the lithium tremor does tend to be reversible, which is really nice, except if lithium was the only thing that helped them and we need to put them on it anyway, which sometimes happens. Lithium, for some people, lithium is just like a miracle drug. Some people it's not super helpful, but the people who it helps, it's very obvious, very quickly, and it can be really life-changing for people, which is neat to watch. We've already talked about most of these side effects. These ones are a little bit more related to Depakote, so I'll point out some of the ones more specific to Depakote. People do tend to get a little bit more sedated or drowsy with Depakote. So sometimes when we have people who just will not go to sleep when they're manic, we will start Depakote, or people who are very aggressive when they're manic, sometimes we'll start the Depakote in those cases because it tends to do better with that type of presentation. It can also have some weight changes. People do complain of increased appetite and increased weight gain. with the Depakote sometimes. It can have some effects on our sex hormones like estrogen and testosterone. So we have seen cases of polycystic ovarian syndrome and problems with fertility related, which are a little less common, but things we look for. Hair loss is not, it is actually a fairly common side effect and complaint, and sometimes people won't connect it to, oh, I started Depakote 3 months ago and it's so weird, I'm shedding more in the shower. And so there's some things we can do to try to help those things if it's really the only medication that seems to be effective. Depakote tends to affect the liver, not the kidneys. So in this medicine, we really monitor our liver function regularly. There are some cases where people do go into hepatic failure related to their Depakote use, particularly at high doses, or if we increase the dose very rapidly. And so we do increase blood monitoring on Depakote as well. It also has a therapeutic range. The therapeutic range is a little bit wider than with lithium, so we have a little more grace and a little more wiggle room with it. But at toxic doses, it can be toxic to the liver and people can get into real trouble. So we do want to only be using this medication on somebody who we can routinely get some laboratory studies on. Okay. I think this is Dr. Cowdery.
Yes. Okay. So then often you're going to notice that we use other medications to treat the side effects when we haven't been able to take our psychiatric medications and lower the dose or find the right thing that we find out that we find the right antipsychotic. The Abilify really works well to control the voices and the paranoia, but I'm really restless when I take it. And so we've got different medications that we can help to treat some of those things. So there's a list of them here. So the benzotropine or Cogentin, Benadryl, Inderal, benzodiazepines are all things that can help with some of those movement side effects that people have. Atropine drops are medications that can help with hypersalivation with the Clozaril. Metformin, oftentimes psychiatrists will prescribe, which you might think is interesting because it's usually prescribed by a primary care doctor, but if we've got a patient who's had some metabolic changes related to diabetes, sometimes we manage that with those medications. I know Dr. Darling has many of her ACT patients on metformin as well. And then there's a few newer medications for tardive dyskinesia. They'd only been out a few years. And so those are newer medications that have seen some benefit. And as you can imagine, if you have a permanent motor dysfunction with the medications and you have to be on them, it's really nice that these new medications have come out. So we've seen some good effects with those two medications on the right.
Sorry about that. I was answering one of the questions.
That's okay. And then Dr. Darling's going to talk about special populations, children and adolescents.
So it would be super nice if kids were just small adults, but they're not. The way they work is a little bit differently. And we also can't test drugs on little people like kids because that would be fairly unethical. So many of our prescribing practices in kids tend to be off-label FDA indicated things, although there are a few things, stimulants are on label for kids. Aripiprazole, I think, or Abilify has some on-label prescribing for kids as well as risperidone. But many of the medications are used routinely to treat children and have been found to be safe in children and adolescents with mental illness. And again, we're weighing those risks versus benefits, risks of not treating a mental illness in a child because they're a child and we're afraid to use the medicine, of brain health over time if we were to go untreated. Sometimes the kids have different reactions and different side effects. One of those things that I can think of, one example off the top of my head, is Abilify tends to be more weight neutral for many adults, but in kids I've seen a lot of weight gain. So it's sort of interesting. I guess I don't really have a good reason why that happens, but it's just one of those things that we tend to notice. Kids do seem to also sometimes need different dosing than adults. A lot of times we think a child definitely needs way lower dosing, although kids' metabolism tends to be much faster than adults. So sometimes they actually need higher dosing than we might think, even though they're kind of a little person. And then the other things that we always want to consider, and this is not just with our children, is we always want to consider other treatment modalities, including psychotherapy, group therapies, behavior management, and things like that, so that we can try to use all different kinds of treatment modalities and reduce the amount of medications and use the least effective doses of medications that we need to.
So for folks that are over 65, we also have to be careful because our bodies change and we metabolize things different as we get older, and we eliminate medications more slowly. So oftentimes we're using different dosages. So the other thing to consider is that many people over 65 are on a whole bunch of medications, and that creates a complicated picture for drug interactions and side effects and things like that. So being very diligent about the medications chosen for people over 65 is really going to be important. Also, things to think about are people might miss doses because they're getting forgetful, things like that. So having ways to monitor those things is going to be really important. So like I said, they're more sensitive to medication. So oftentimes we're using lower dosages of the medication. And we want to make sure that the person and their family members talks to the physician if they notice any changes that can affect like alertness, memory, coordination. We don't want to put people at risk for falls or anything like that. And we want to make sure that we talk about those things and that people are aware of them so that we can quickly act if something like that is happening to prevent any sort of other, long-term effect of the fall, like a hip fracture or something like that. Memory problems, like I said, can affect. So we want to really make sure that we've got a system in place to help people take the medications. So they don't take too much or too little. Imagine if you have a memory problem, you might not remember that I took my morning meds, and then I took my morning meds, and then I took my morning meds. So just a 7-day pill box can be a really easy way to set those up at the beginning of the week. And actually, I recommend these type of things for everybody, not just over 65. That visual reminder can be really good. Remember to take the medication, but then you also know that if you took it that day. So I know, especially with COVID, none of us know what day of the week it is. So that can be helpful.
Pregnancy and postpartum can be a really tricky time in mental health treatment and needs to be very much individualized towards the woman, her family, her baby, and between her doctor and consultation, hopefully with the OB-GYN who is taking care of the woman. We need to weigh the risks and benefits of all the treatment options during pregnancy and in the postpartum phase, particularly if the woman's going to be breastfeeding. And, the risks. So sometimes I think in general, we forget about the risks of not treatment. We only think about the risks of the medicine, but there are certainly risks associated with not treating a serious mental disorder, right? If we don't treat somebody's depression or psychosis or bipolar disorder, they could get very sick and end up in a hospital or end up in jail or end up with a suicide or end up with all kinds of bad outcomes. And so is the theoretical risk of a medication that may or may not have been shown to have risk really worse than those risks? And most of the time they're probably not, particularly if somebody is stable before they become pregnant on medication. There are a few medications that are like big no-nos, like no matter what, we cannot give them, especially at certain times in pregnancy, but there are actually very few of those in psychiatry. That's going to be some of our mood stabilizers like Depakote has been shown to have some birth defects associated. So if we know somebody's going to try to become pregnant, we would certainly want to try to get them off of the Depakote, or at a very minimum supplement them with some folic acid and some other things that can help mitigate those risks. But most of the other medications, I typically in my practice will consult with my patient and their OB and say, what are our goals here? What do we want to try to accomplish? If the patient is very, very stable on an outpatient basis and their medications have not been shown to have problems in human fetuses, we will often continue the medicines and watch very closely and have very close monitoring by the OB-GYN with labs and ultrasounds and things like that to make sure that the baby is growing normally. If they are on one of those medications that we absolutely have to change, then we will under very close supervision. I think there's like historically people were like, I'm pregnant, I have to stop all my psych meds. I tell my patients, don't do that. That's going to be really bad. Let's do this together. If the patient's too scared to be on a medicine because they're really worried about that, then we take that into consideration. But surprisingly, a lot of times we'll either keep the patient on the medicine. Sometimes we have to actually increase the dose because the woman's fluid volumes actually increase when she's pregnant. And so she may need more medication. Things like benzos have been shown to have some problems in pregnancy, so we do try to avoid those mostly. Lithium has been shown as well to have some problems, although not as many as we used to think. And we will avoid that in pregnancy as well if we can, although there are times where I've absolutely had to prescribe lithium in pregnancy to prevent mom from getting manic and psychotic and dangerous. The floppy baby syndrome that's sort of described there tends to be sort of self-limited, and the babies do tend to be okay. Very, very infrequently do they need intervention. SSRIs can also have sort of a withdrawal syndrome in the babies, although most of the SSRIs, the only one we would not want to use in pregnancy is Paxil or paroxetine, have been shown to be fairly safe in pregnancy. People who have a history of depression have an increased risk of postpartum depression. And so even if they're getting through their pregnancy just fine, sometimes if they go through some of their pregnancy without the medication, we'll look at starting it before they have the baby or right when they have the baby to try to prevent that postpartum episode.
One quick question, can the father in treatment pass on birth defects to a baby if they are taking some of these meds?
I have never heard of that.
Okay, thank you.
Sure, good question. I haven't thought about it much either, but I've not read anything on that. I've actually done quite a bit of reading. I've had several pregnant patients here in our clinic. Antipsychotic medications, same thing. They're Latuda has often been used because before we got rid of our categories, was a category B, although it's fairly new and there's not tons and tons of data on it. Haldol has been studied mostly because it's been around the longest. So when you're there the longest, we have the most information about you. But most of the antipsychotics have seemed to be safe in human babies. Some have had some problems in some of their animal studies. But we haven't found like a clear link to a specific birth defect like we have in something like Depakote, which is why we try to get people off of something like Depakote. So if somebody comes into the hospital and is not stable anyway, then we would probably try something like orazidone, which we know is a little bit more safe. But if somebody is perfectly stable on a very specific medication regimen and life's great, they're working, they are in a happy relationship, they're excited to have a baby, it's going to be hard for me to be convinced to go, we should totally change that to a completely different medicine and just hope for the best. Because, I'm sure many of you have experienced it can be a lot of trial and error and heartbreak finding the right medication. And to do that in a time that's kind of high risk in pregnancy can be tough. So again, it's very, very individualized in these cases. Antidepressants, most of the SSRIs are considered safe. So again, I wouldn't jump to take somebody off. Prozac and Zoloft in that category have been around longest and probably have the most data to support their use. There can be a little bit of a withdrawal syndrome where the baby can be a little bit irritable or jittery, and typically this babies do real well and within a couple of days are back to their normal baby selves. And same thing with breastfeeding. Different medications get into the breast milk at different rates. And we really need to look at the risk benefit of breastfeeding versus alternative options and how important that is to the mom and to the baby and to their relationship and the health of the baby versus how important is it that that mom stay on the medications and maintain her mental health stability.
All right, so this is our last section, and then hopefully we'll have a little bit of time for questions. So we'll just kind of wrap up by talking about some of the challenges that we have with psychiatric medications. And Dr. Darling and I like to be very real with how these things work and what we experience so that we figure out how to help people the best. So just if we think about human beings in general, do not always take their medications regularly. People can forget, they don't make it a habit or a priority. They take them inconsistently, and then often people will take them, they'll feel better, and they'll stop the medication. Just think about a time maybe where you were prescribed an antibiotic for an infection, and you started to feel better, you got better. Did you really take the full, 14-day course? Yeah, most people will stop after 7 to 10 days. So just thinking about normal human behavior is going to be really important. People's insight varies. Why are they taking the medications? Are they taking it because they're on a court order? Are they taking it because my mom says I have to be able to live in her house? Or are they taking it because they really want to feel better and they're at a point where they don't feel good? So along with that insight is the buy-in. And that's when I give the example of the young person when I needed to take a girl out on a date. We really have to figure out the buy-in. What is the buy-in? Why are you here? And what's going to help you get motivated for treatment? And so sometimes that can take a long time, and you want to usually use those shared decision-making and person-centered principles to get to that buy-in. Court-ordered treatment, so that's when people are forced to take medications against their will. They've been told by a court after evaluation by doctors that they have a mental illness, needs treatment, but maybe they lack the insight. So this can have an influence, and it can have an influence both positive and negative. The positive of it might be that it gives enough time for the medications to take a hold, that then the person has insight after. Maybe after 3 to 4 months on an antipsychotic, they can kind of see that, maybe the FBI isn't after me, and maybe my brain was playing some tricks on me. So it gives us time to help with that, which is a positive thing. And they may recognize that they want to get treatment and they don't want to feel like that again. They don't ever want to end up in that hospital against their will. We can also have a negative effect for some people that don't have that insight. It's not me, it's the court. It was my mom that filed the petition. I don't have a mental health issue. And then their first exposure to mental health is forced. So as you can imagine, if your first, treatment for a disorder was forced against your will, that's a really challenging thing to go to. It doesn't give you the greatest eye about psychiatry. I can't tell you how many patients have walked into my office and said, I don't need to see a psychiatrist, I don't have schizophrenia, and I don't need to be on this court order. And that's a real challenge for folks that their first introduction to a psychiatrist is that way. And so you really have to partner with people. And it's really nice when you can get to the end of the court order and they're like, I didn't know a psychiatrist could be cool. Thanks, man. Thanks for helping me out. So you've got both pieces of that. Also, people wanting an immediate fix for something that didn't happen overnight. Oftentimes working with families, after a young person or their family member has been through treatment, they say, well, now we've got treatment, he should be better. And that's not always the case. This took a long time to happen. As if we play Monday morning quarterback, we can look and say, yeah, actually, this has probably been going on for 1.5 years or 6 months. And so we can't imagine that taking the medication once and then, everything's going to be magic. It takes time for people to heal and get better. The other piece is that, we've talked a little bit about advances in psychiatric medications, is that we need a lot more attention paid to mental health research. We really need more advanced treatments, and that includes medications, therapies, neurostimulation, that genetic testing we were talking about. I do think one thing that will come out of COVID-19 is that there's a lot less stigma to mental health. Everybody's talking about how depressed or anxious or fearful they are. So I really think that that's going to be a helpful platform for more advancements in our science of psychiatry, because I think we've kind of been left behind because other topics are more of interest to people and don't have the same stigma that mental health care has. And then the other piece is that medications are not the only answer. they're just a part of the treatment, and they have to be combined with many different modalities. And that includes a lot of things. It includes therapy, it might be family support, community support, friend support, exercise, nutrition. It might be increasing your different activities, doing things that are fun, doing things that make you laugh, having a regular routine. So there's a whole bunch of tools that we have in our toolbox, and it's really important that we utilize all of them and figure out where a person is and which tool we need to use at the time. Another thing to think about is what environment we're in. So how we can initiate and adjust treatment. When a person's on an inpatient unit, it usually means things are not going that well, right? And we need to act faster. So we're in a controlled and safe environment where we can get vitals and labs, and we can monitor you. There's staff 24/7 that see how you're doing. So what we do is we treat faster, and we treat with higher doses, which may have a person being more sedated. They may feel physically uncomfortable and have more of those side effects, but we can treat the medications faster so that we protect that brain and get it back to functioning better. Outpatient, we're going to look a little bit different. We are in an uncontrolled environment. You're going home. I don't know if you're taking the medications every day. I don't know if you're using substances. I don't know what else is going on. So we're going to go slower. And I also don't want to expose you to more side effects, just as Dr. Darley talked about with the antidepressants. If it's not going to work for 4 to 6 weeks, let's take it slow so that you don't have that stomach upset, that headache, all of those things. And so, I mean, there are times we go faster outpatient if there's a reason, like I need to get better before I start school in a month. Then we might do that, but we'll really talk about, you're going to have a lot more side effects. You know, you're going to not feel well for a while we adjust this. So having those conversations, and that's why, you know, people and family members may react to the medications differently, because they're like, why did they completely snow me when I was an inpatient? And what we're trying to do is protect your brain from that mania and psychosis and get the medications on board as fast as possible so that we can help. But it can sometimes be uncomfortable, and family members can be concerned about those things. And then the opposite with outpatient, like, why can't we make this go faster? Well, there's a reason behind what we're doing. We want to try to protect people from the side effects in that environment, and also protect from, you know, jolting anything in somebody's life. You know, if we change a medication slowly and it causes something, maybe it causes you to be really agitated, and then, you know, something happens at work or school, we want to be able to catch those things quicker. So we want to talk a little bit about patient responsibility, because sometimes in mental health, the responsibility can be placed on the psychiatrist or on the treating team, and we really want people to own this. You know, I really teach a lot about, this is your body, this is, you know, your medical condition, and you have to own this, and you need to tell me everything that's going on so that we can partner together and work well. So telling the doctor about any medications or vitamin supplements you're already taking, and that may mean bringing in those vitamin supplements so we can look at it. Because there's all sorts of brands, there's all sorts of things, you know, really understanding what that is so we can look at it together. Telling about allergies or problems you've had with medications. It may seem like very detailed information, but it really helps us try to figure out what to use and not use to protect your health. Understanding those medications, you know, I'm sad when people are like, well, I don't know why I take them, my psychiatrist just prescribes them. I'm like, no, it's your body. You need to know what you're putting in there and what it's for. And if anything ever happens, you need to be able to tell somebody about it. Don't take medication prescribed for another person or given to someone else. Those can have dangerous implications for your body. And I know commonly people, you know, oh, I took my sister's Xanax or this, and it's really a challenging thing, because there's a reason doctors prescribe medications based on your entirety of your medical history. And if you're just kind of taking one randomly, we don't know what's going to happen to you. And so it's really important not to use anybody else's medications or share your medications. And then calling your doctor right away if you have problems is going to be important, because oftentimes people will just, you know, stop it or be like, oh, I'll see them next month at my appointment. We don't want those things to happen. We want to be able to, you know, give us a call. We'll try to adjust faster or get you in sooner. You know, don't just stop and say, okay, well, I'll get it at the next appointment. Let us know so that we can help you in that moment, so we don't interrupt the treatment and make things worse. So lastly, here we've got some resource slides. The National Institute of Mental Health has really good information. That's where we got most of the information for this presentation. The Food and Drug Administration website has the latest warnings, medication guides, new medications, and then Medline Plus is also a good resource for patients if you want to find up-to-date medication information. And again, like I said, there's lots of information on the web, so use scientific based information. And then those are just the references for our slides. So it looks like we've got a little bit of time for questions.
I think we had one that was about, let's see. Let me see. One was about some of the medications for migraine treatment were also listed in the slides.
So yeah, definitely, they can be used for, you know, as Dr. Darling mentioned, sometimes when we start a medication in one manner, we learn that it affects another part of our body or how we do. And so yes, they're commonly used together.
And then another comment about many times PCP obviously are not looking at meds prescribed by psych. Do you have a suggested technique for psych to coordinate with the PCP in a way to look? I would think the medical electronic records should show you everything someone's on. I would think.
Yeah, and it's great if you can get your care all under one umbrella. So like with Valleywise, we have primary care and we have behavioral health. We also have specialty services and we have hospitals and we have medical hospitals, psychiatric hospitals. So if a person goes into any of those places, then we see the medical record. So that's really nice. Now, it might not be the case because maybe you really like your psychiatrist at one place and you really like your PCP somewhere else. We do attempt to coordinate, and like I said at the beginning, psychiatrists are pretty good at this. We definitely are going to be calling more and seeking out the primary care doctor. We'll be obtaining records, but I also think there's a part of that personal responsibility for the person to take their list of medications to their PCP and say, or the card, like here's the card for my psychiatrist, they want to talk to you too. So anything we can do to improve that coordination is going to be really important.
I was just going to add that when I try as hard as I can to get our people, if they're willing to see our PCP, because I have a meeting with her once a month and we go over all of our patients in common, and that really helps with those folks. But I certainly have people who've been with the same PCP for 15 years and they're not going to leave just because I think they should, and I don't think they should, because they should stay with the doctor who knows them best. And if I do have challenges getting that person on the phone or to respond to me, sometimes I'll print out my labs and my med sheet and hand them to the patient and say, please take this with you to your appointment, and help them guide that conversation. So here's the types of things you want to make sure you're telling your PCP about so that they know what's going on, and giving some of that onus to the patient themselves.
We did have one about, do you have a preferred place to find information about specific meds, for example, about the negative effects of benzos or interactions between benzos and medical marijuana? And he has tried scientific research places on that last slide.
Yeah, so I would use the ones that are on those slides. It's going to be more challenging to find information about like the marijuana and benzos, because there's a variety of different studies and things that are out there.
And we've had lots of people that give you accolades at Valleywise. I hear it personally when families call and they want to know how can they get their loved ones back in Valleywise and not in some of these other clinics or areas. And another one just about they wish you practiced in the San Diego area.
Yeah, and I know that, you know, we have a strong commitment to quality care. We're the safety net hospital system, so we have a strong commitment to underserved populations and doing a good job. We also, because we have our residency program, you know, folks go through our training, and most of I think all of my docs in our outpatient clinics trained through our program. So there's a commitment level there to maintaining a quality of care that's really important. So there's a very good attitude and want to help folks.
Okay. Well, we're at 7 o'clock. You guys are fantastic. I can't think if I ever need a psychiatrist, I'm coming to you. If I have a first psychotic break, can I get in first episode, or have I aged out?
Give us a call. We'll figure out where to go.
Okay. Thank you very much.
Thank you so much for
Thank you,
having
guys.
us.
Yeah, thanks.
Thank
Have a good
you.
night.
You too.